sufferers do not respond to conventional therapies such as antibiotics or anti-inflammatories. Any ideas? Yes? Okay. You're just so well-rounded. It's perfect.
She's a nurse.
Oh, this is why. Okay.
Not giving away the secret.
She's cheating.
All right. Doctors seldom agree on the cause, cure, or treatment, which then also leaves you wondering why we go see doctors, because they just give you a random diagnosis because they don't know what to do. Because nothing is working. Not even surgery, no medicine, nothing is working. And they don't know what to say, so they just give you something like IC, interstitial cystitis, or painful bladder syndrome, or chronic prostatitis, or something random. Patients will suffer from this condition for years, and their lives become absolutely miserable. And this condition is caused by the overuse of the human instinct to protect the genitals, rectum, and the contents of the pelvis from injury or pain by contracting the pelvic floor muscles, creating an inhospitable environment for nerves, blood vessels, and structures throughout the pelvis. Now, this last point is sometimes discouraging for some people, but there is no simple and quick solution to treating this condition. It takes time. It requires a lot of devotion to eventually be freed from this condition. What am I?
It's like a rectal.
Nope, it's not urinary or fecal incontinence. So we have urinary incontinence as well as fecal incontinence. That's actually another condition. So when the umbrella of conditions, right? So fecal incontinence falls underneath that. In fact, I found out a new statistic on that. 1 in 4 women over the age of 40 will have fecal incontinence. They will not be able to control their stools. Over the age of 40, 1 in 4. That's incredible. I just took a menopause course this weekend, and it was phenomenal. I was just, that blew me away, because this is something women don't talk about. And this is embarrassing. So what is this condition here, though? So this is the one that I said that nobody, do you know what it is?
You could tell us.
You're dealing with stress incontinence.
We've done stress incontinence, yeah. We've talked about pelvic organ prolapse, and this is the 3rd most common one that I see coming through my doors.
And then I say no, I don't.
Okay, that's okay. It's chronic pelvic pain syndrome. Okay? And this is really, truly life-altering. It gets to a point where these people cannot sit, they can't stand, they can't lie down, they can't function, they can't think. It's just all consumed. They've gone to every single doctor you can possibly imagine. They've tried every medication, and there is nothing that works until they start getting the right treatment. Again, I'm going to repeat this. In our highest level of medical evidence, pelvic floor physiotherapy is the first line of defense against these conditions before drugs and surgery. I can't emphasize that point enough, because everybody deserves to receive the proper care and not the wrong care, not the care that's going to actually probably create even more problems. And we have to get to the root cause of this. And when we start to discover this area of our body and we start to learn how to let it go and how to let go of that chronic tension that we're holding in there, and we'll talk about that, that's when we can get freed from these conditions. These conditions are very, very tricky to treat and to resolve, but they do. And the problem is that people aren't willing to put the time and effort into it. Okay, and they just keep brushing it off. But when it gets to the severest points, they can't keep brushing it off because their life is done. They cannot function anymore. So I actually really enjoy working with these ones, because this is really about bringing somebody from the lowest point of their life to giving them hope and then getting them to live again. And it's just fascinating to watch that progression. And they just have to believe that they have to create the time to take care of themselves. And it's just the body's way of screaming at you and saying, hey, you can't keep living this way. It's not working for me. And not everybody is going to present that way, but we're all going to have, if we are too much one way and we're not taking care of ourselves in other ways, at some point something is going to yell at you. Whether it's pain, whether you get some form of incontinence or some kind of urgency, frequency, anything. But most of these conditions, especially with this chronic exposure to stress, they will present themselves in the pelvic floor because of the anatomy of the pelvic floor. And I'll say it now, and we'll get into it in a little bit more detail. The pelvic floor muscles are, which brings me to my next slide here, so we might as well just go right into it. The pelvic floor muscles are a series of muscles that basically are like a sling or like a hammock that run from the front of the pubic bone to the back of the tailbone, and then from the side of the hip bone to the other side of the hip bone. and they support the internal organs that live within that cavity, but they have 5 main functions. 6, but we'll talk about the 5 main ones and then we'll touch on the 6th. But to the initial point where I said, why is this area most responsive to stress or chronic exposure to stress? These are the only muscles in the human body that adhere to the walls of the pelvis via something called connective tissue. So you know when you're cooking your chicken breast and you take that shiny, that thick kind of dense piece of coating off of that? Well, that's connective tissue, and we throw that out. But in your body, connective tissue just covers your entire body from head to toe. It divides your skin from your fat, fat from muscle, muscle from bone, and in this case, it divides and compartmentalizes every single organ, tissue, nerve, artery, vein, everything is divided by this connective tissue. And because these muscles are glued to the walls of connective tissue, whereas every other muscle in our body goes from muscle and then it becomes a different structure, it becomes a tendon. So it's no longer muscle, it's becoming a tendon. And then the tendon anchors onto a bone. But we can't have that anatomy here because this anatomy says, no, too much force, or too much stretch, and it'll tell the brain, stop, stop, stop. But you can't say, whoa, stop, 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 can't have that baby. Can't have that structure there, and you can't have that because there's so much stress that's acting on this part of the body day in and day out, from coughing, jumping, running, everything we do, sit to stand, lifting weights, whatever we do will act on this floor, and so the pressures can't have these tendons in them. But in response to stress, connective tissue does this in an effort to mobilize the area so that it doesn't move and to keep it safe. But does it let go if you're chronically exposed to stress? No. It stays tighter and tighter and tighter. In fact, there was a study that was done where they put EMG or muscle readers on various muscles throughout the body, and then they put threatening images up on screen, and 100% of the time, the pelvic floor muscles go like this first, before any other muscles in the body. Isn't that fascinating? So chronic exposure to stress will cause these muscles to tighten up, tighten up, tighten up, and there are incredible amounts of nerves. The spinal cord comes, the brain is here, the spinal cord comes right through this canal here, and all these little holes and all these little branches are areas where the spinal cord divides off and then it innervates, or all these nerves run through the legs and run through the pelvic floor. So you take a muscle and you go like this on nerves and arteries. Over time, they're not going to be happy, and you're going to know about it. And it's going to start screaming sooner than later if you don't learn how to let go. The issue is when it's been 20 years of chronic exposure to stress and you had a fist like this, held like this for 20 years. Let's say all of a sudden after 20 years of holding my fist like this, and then after 20 years I finally figure out how to let it go. Is it going to feel good? No. It's going to hurt. Everything. To touch it is going to hurt. So it's not just your ability to finally figure out how to let it go, it's your ability to keep it there over time. And that's why that final point takes devotion and a lot of commitment. And that's why this condition is probably one of my favorite to treat, because I have to stick with them through the entire journey. Okay, so the other function, other than what we said with regards to support for the internal organs, these muscles of the pelvic floor also allow, they have a sphincteric function, which means they keep us continent, right? So they have circular muscles that basically go around the urethra, which is the tube that comes out of the bladder, and it squeezes on the urethra to make sure that we don't pee. And then we also have the sphincters that go from the anus to make sure that we don't have stool leakage, okay? Then, this one was actually really interesting because I learned this one at the menopausal course. So the sexual function. Now, we all think of the clitoris as being, and because we're all women, we can talk about this, we all think of the clitoris as being the only organ that we can stimulate to have an orgasm, right? But the reality is the clitoris does not just live here. The clitoris actually has a body and it has legs. So, to increase your pleasure with an orgasm, go and stimulate the other areas. Go and stimulate the leg and the body of the clitoris, and you will significantly feel significant improvement in your orgasm. Okay? This is pretty phenomenal. And the issue here is that a lot of women in their menopausal years, they want to have sexual activity with their husband or their partners, or maybe they met somebody new, but it becomes painful because they've lost estrogen. And now the tissues down there start to dry up. And then it starts to get quite brittle, and they tear, and it can be quite painful to have activity down there if these tissues have not been utilized, especially if they continue to weaken over time, right? If you don't use it, you lose it, and then take out the estrogen, and then it becomes quite painful at this point, okay? So it's always important for women to become connected to this area, because what often happens is we're like, oh, I don't even want to think about it, and you just completely disconnect from this area of the body, which is the worst thing you can do. You need to reconnect. Women need to pleasure themselves. They need to find these areas again, use these muscles again, so that they can again resume sexual activity with their husbands or partners. Okay, it's very, very important. And then obviously these other areas, these are all here, these muscles here that surround the clitoris and the vagina are all involved in sexual function. So we look at releasing these tissues if needed to help get some flexibility through the muscle again, so that it is no longer painful. And there's other treatment options that we utilize to address that. Now, stability. So they provide stability for the pelvis, and these are internal stabilizers, whereas we also have external stabilizers. So the leg consideration, we can't always just think about the inside, but we have to think about the outside as well. But they do provide support for the pelvis and stability. And then the sump pump action, that's the ability of these muscles to fully stretch and then fully contract. So if you have a muscle that's stuck here, would you go do some weight lifting on that muscle? Or would you be more inclined to figure out how to stretch it out first? What would you do? Right, so if a muscle's stuck, you're not going to go and squeeze, right? So we think sometimes of doing the Kegel, because that's often what everybody knows, is do that Kegel or stop the flow of urine, which is a lot more complex than that. But you can't, if you've never had your pelvic floor assessed, then you shouldn't just be doing a Kegel because you think that's what you need. Because if your muscle is stuck and it's tight and you go contract that, you might actually end up in that chronic pelvic pain category. So this is very important. It's not just, oh yeah, just do your Kegels like doctors often do. They don't internally assess you. They don't actually check to see what's going on. And that's what we do, is we do an internal assessment and we check to see what the integrity of the pelvic floor muscles are. And this is why I brought this here, and I'll pass it around so that you can see. But what happens is that we'll go in vaginally and we'll check all the muscles. We'll check for any trigger points. We'll check for the ability for you to squeeze around the finger. We'll check to see if it stretches well, if you relax it well, right? Do you have endurance? Do you have power? Or is there even any activation in the area? So we have to go and check that internally to make sure that these muscles are actually going to get the treatment that they need. Does that make sense? Okay. I'll pass that around. You can have a look at that. Okay, and then I also mentioned here another role of the pelvic floor is in posture and breathing. Now this is really big, and you guys see all these balloons around because we're gonna use these balloons in a minute. The posture and breathing play a huge role on this. And I'll just go to the next slide because it's part of the secondary function of the pelvic floor. And what we have here is we have the diaphragm that lives at the top, and it makes up the roof of this system. So the pelvic floor muscles don't play alone. If you want 100% restoration or function of the pelvic floor, you need to consider the friends that play with the pelvic floor. Okay, so you've got a huge diaphragm up top. It kind of looks like a stingray. I don't know if you've ever thought of a diaphragm as looking like a stingray, but it really does. If you look at a diaphragm like in a cadaver and you open up a cadaver, none of you guys have done that? That's weird. Anyways, no, okay. So it does. It looks like a stingray. So it's this big kind of flat looking muscle that when we inhale, it flattens out and the pelvic floor muscles expand or stretch with the inhalation. And then we've got this big muscle that wraps around all this soft spot, all this soft stuff that's between the rib cage to the pelvic floor is called a transverse abdominis, and that's truly your girdle. There are times when that muscle will tear right down the middle, and it's something called a mummy tummy or a diastasis rectus abdominis is the medical terminology, but it's that separation in the abdominal wall that most women will experience in their third trimester of pregnancy, and whether or not that wall comes back together or not often is overlooked. So they could be living with basically a ripped muscle wall their entire lives, wondering, why does my back hurt, or why is my organs falling, or whatever the case may be, whatever the symptom is. So oftentimes, if that is severe enough, yeah, I'll take your question.
Is that the same as a ventral hernia?
No, that's an umbilical hernia.
A ventral hernia.
You're referring.
I'm thinking the old name that I remember was ventral hernia. So it's not umbilical.
So it could be a ventral hernia. I've never heard of that terminology. The terminology, yeah, it might
I think
be.
what you're talking is the rectus, yes.
Yeah, the diastasis rectus abdominis,
yes.
as I know it. Yeah. So, and then so in cases where it's quite severe, we would get a form of bracing for the time, especially when there's relaxin in the system, which is that hormone that women have up until 3 months after they've stopped breastfeeding. So a lot of women think right when they finish their pregnancy, it's out. It's actually not. So we really need to help brace and keep those two muscles together so that they can find each other and start healing in that proper form, because this muscle is extremely important in the overall function of the pelvic floor. So, like I said, with inhalation, the diaphragm drops, the pelvic floor lengthens, and then the abdomen should expand. So what we're going to do right now is we're going to test this out and see if we can all find that inner core and get a sense for where our pelvic floor is and see if we can feel it. So what we're going to do is we're going to take the balloons that you have on your table there. Oh, did you not get one?
There's an empty spot here.
I have some extras here if you have. If you don't.
We're good.
We're good. We're gonna make. Are you sure? Yeah, for sure. Okay. So what we're gonna do is everybody's gonna just kind of back your chairs up a little bit so that you can sit on the edge of your seats. And then I know some of us are wearing skirts, so we're all kind of covered. So if you can actually open your legs a little bit and sit like so that you can tip your pelvis. And what we're going to try and find in our bottoms are these two sit bones right here. And the sit bones, I want you to slouch back, round back, and go into that posture. Sit on the back of them. And then I want you to sit up tall and find the front of them. So just become familiar with the two bones that you're sitting on, your sit bones. Can you feel the front of them? And then can you feel the back of them? I'm just going to quickly come around. That's beautiful, very nice, perfect. And then don't be afraid to go all the way forward and really feel the back end of them versus the front end. That's beautiful. Very good, ladies. Perfect. Okay, so now let's stay on the front-ish part of them, so neutral to more front, because that is the optimal position for the pelvic floor to find strength. We sit, often slouched, through the process of the day. But what happens is that these muscles get chronically stretched and weakened, and there's a deficiency in the back of the pelvic floor. So if you're trying to restore function of the pelvic floor, you don't want to do it in a weakened position. So you want to try and get into a better optimal position where you can create some strength, and that's on the front of those sit bones, okay? So now that you're all in perfect posture, sitting up as tall as you can, I love it. Wouldn't it be nice if we all just lived this way? Okay, so now what you're going to do is you're going to take your balloon, and you're going to blow up your balloon, and I want you to think, what is happening to the space between my sit bones? I want you to think about your vagina and your anus. I want you to tell me what is the experience you're having down under while you blow up that balloon. Give it everything you got. Off you go. Just pay attention to what's happening down under. Everything you got. If you don't care, or if you don't mind sharing. What did you feel? Squeezing, like you're trying not to pass gas? Okay, so like you're trying not to pass gas, you're trying not to leak. Okay, you felt contraction down there. Anything else? Bulging. That's the other one. Okay, so you felt like there was a pooping sensation, right? Okay, so a drop in the pelvic floor. Okay, and that's exactly what your pelvic floor can do. It can either squeeze, or it can allow you to, it can either stop you from peeing or pooing or farting, or it can allow you to do that. All three of those things, right? So it's one of the two that the pelvic floor is going to do. So now I'm going to ask you to do the same thing, but whatever you experienced the first time, do the other thing. So just don't pee. Or at least try not to. No, seriously though, if you're concerned about that and you think you're actually going to pee, don't do it. Okay, there's no need to embarrass yourselves. But if you feel comfortable enough, just try and see if you can blow up a balloon and let go of the pelvic floor, as opposed to always feeling like you need to tighten it. Because with urinary leakage, the common practice or habit that starts to develop is that women will keep very, very tight in their pelvic floor all day long. And then when they really need to go to the bathroom, the pelvic floor muscles are exhausted. And then the bladder's now full, so now they put weight on an exhausted muscle, and you lose your chance at even trying to be continent at that point. So it's very important not always just to Kegel, but to reverse Kegel. To be able to let go is just as important as it is to contract. So let's try that. Just allow yourselves the feeling of letting go. What does that feel like, and can you even do it? Perhaps it's harder than you think it is. Perhaps letting go is not something that we're accustomed to. experiences as to whether or not you were able to do it, but you have to think about that on your own. And you need to think, well, was I able to do the opposite of what I did before? Where I really have control of those muscles. Sorry. It's okay, you guys can let them go. But you really have to ask yourself, was I able to do both? Did I feel comfortable doing both? Or am I lacking some control in that area? And if you are, and you're concerned, then please come and see me afterwards. And if not me, find a pelvic floor physio, because these conditions are not going to improve on their own. You need to pay attention to these muscles, and you need to become familiar with them and regain control of these muscles. Does that make sense? Okay. All right. Okay, so what causes pelvic floor dysfunction? We've kind of touched on some of this. So weakness or excessive tension in the pelvic floor muscles, such as obstetric trauma, which is, like I've mentioned, the forceps, the suction, the tearing, the episiotomies, all those kind of things. A lack of endurance in the muscle. C-section scars and mummy tummy. We touched on the mummy tummy, which is that abdominis rectus that we touched on there. And so this is an image of what happens. Okay. Scar tissue from a C-section or even a hysterectomy or any abdominal surgery can impact the function of the pelvic floor because of that star player in our body, the connective tissue that has over 100 million nerve endings that activate it, and in response to stress or trauma, it tightens up. Well, this part here is very, very connected to the second layer of the pelvic floor muscles. There's 3 layers to a pelvic floor, and there's a sexual layer, there's a sphincter layer, and then there's the pelvic diaphragm. And the sphincter layer is the one that's directly correlated to any abdominal traumas that happen in here. So that could be a big cause that we can't overlook when we're going through our treatment. Poor body awareness. So like we just did, maybe some of us experience that we don't really feel anything down there. I don't really have the ability to squeeze, or maybe I don't have the ability to let go. So that's just not being aware of what's happening. And in my Unit 1, my Finding Your Inner Core pelvic workshop that we'll talk about at the end, this is where we start to become familiar with the breath. If I was to ask you all to take the deepest breath you can possibly, can everybody just stand up for just one moment? We're going to test this because I'm always and it's a nice break for everybody. Can you just all take the deepest breath you can possibly take? And then let it go. Fully in. And let it go. Now if you place one hand on your chest and one hand on your abdomen, now do it again. Fully in. And let it go. What hand is moving when you inhale? Is it your top hand or your bottom hand? Okay. Most of us are the top, are shallow breathers. And this actually causes the pelvic floor to go up. So you're actually not getting that beautiful piston that happens with belly breathing. There are over 3,000 ways to breathe, and we only use one, and we use the worst one, shallow breathing. We have to be able to retrain the body to be able to breathe into our core and then all the way into the pelvic floor. And when you become proficient with your breath, you will actually feel your pelvic floor muscles letting go and lengthening with your breath. And it is quite fascinating when you can actually feel that pelvic drop. So when we inhale, we don't suck in. When we inhale, we let out the belly. And the pelvic floor drops. And then the opposite holds true. So this is all about that body awareness piece. You guys can have a seat again, thank you. This is all about that body awareness piece. It's not knowing how to control our breath. Can you do both? And that's the simplest thing we use on a day-to-day is your breath. But can you use the right muscles to breathe so that you're not in a state of chronic stress? So that you actually give the signals to your body that it's okay, it's time to rest, digest, and heal. Because if you breathe here, that has there's a sensor in the carotid artery that when you use this area of the body, it actually is connected to your fight or flight system, which is your stress system. Whereas when you breathe here, you get the rest and digest, and that's your fight or flight system. So that's the system that we want to stay calm, cool, and collected. But yet this one doesn't ever work. It's always the fight or flight. And this rest, digest, and relax system won't work unless we learn how to shut this one off. So through core and belly breathing, we can actually shut that one off and give our bodies a chance at healing. All right. These are the 2 medical terms to refer to weakness or tension. So a hypotonic pelvic floor or a hypertonic pelvic floor is weak or tight. Now, can we have both conditions that exist together? Can you have a weak pelvic floor and a tight pelvic floor? Absolutely you can. Okay? And here are just a series of symptoms. I know, sorry, I wish that the screen was a little bit bigger, but these are symptoms. Can you read them or not particularly? So, hypertonic pelvic floor muscles, if you had tight pelvic floor muscles, you might have symptoms like urinary frequency, urgency, hesitancy, stopping and starting of urine stream, painful urination or incomplete emptying. You might have constipation, straining, pain during or after bowel movements. You can have unexplained pain in the low back, in the pelvic regions, in the hips, or in the rectum. You might have pain during or after intercourse, during or after orgasm, and the same thing during sexual stimulation. And this is another big condition that I treat as pain with sex. This is actually very prominent. Now, or uncoordinated muscle contractions causing the pelvic floor muscles to spasm. Then on the other side of that, hypotonic muscles is that heaviness, so that would be that prolapsing, that bulging, that pressure. You would have urinary leakage, fecal incontinence, which we touched on, and then unresolved low back and hip pain, because if you don't have stability in that area, then you're going to have flimsy joints that aren't being provided with that base of support. The inner core, guys, is the most important part of the body. When I was in physio school, I didn't understand why we kind of skipped through this area of the body and then just went down, right? And we didn't look at this part because it didn't seem to be important. But afterwards I realized this is the glue, this is the foundation that holds us together. These are the stability muscles of the body, but yet we don't see them, we don't know about them, and we go through our entire lives without ever trying to find them. And this is why I dived into this area, because it is the most important area of the body, and we cannot build a strong house on a cracked foundation. So the treatment, we touched on a few of these, okay, and I touched on the fact that Kegling is not always the answer, okay. You've really got to come and get your pelvic floor assessed, if not by me, by some pelvic floor physio out there. There's not a lot out there, but I'm happy to give you a reference if you don't live in the area that you can go and search and find one. My job is to raise awareness about this so that everybody gets the right health care and not going down the wrong paths. The treatment, again, like we've mentioned, is really focusing on finding that inner core, learning how to breathe. We do the trigger point releases, which I touched on. There's scar massage. We rehabilitate that diastasis if there's any issues there. We work on the stress management, the relaxation techniques. We look at nutritional considerations, because there are a number of foods out there that are bladder irritants. If you have urgency and frequency and you're consuming these foods, that could be as simple as just don't have those. Right? And then we have to look at menopause and how that also causes more sensitivity to the bladder, right? And we've got to consider the menopausal changes that come and can impact these conditions. Then we look at peri-pregnancy training and postpartum training. There's very specific ways to position the body and to push a baby out, which is not something that's taught by your OBs, or if you have a midwife, you might get the proper teaching, but it's often overlooked, and there's very specific ways. But the way we give birth is on our back. The sacrum is a very important bone. It has to move in what we call counter-nutation and nutation. When the baby arrives into the inlet, the sacrum has to move back to allow the baby to come in. When it's going out the vagina, the sacrum has to counter-nutate to allow for more surface area. But when we give birth like this, that doesn't happen. So now we've got tons of trauma that happens to the pelvic floor. So positioning, sideline, on all fours, squatting, those are ways that we train the mom to start pushing. And there's a very specific way to push a baby out. And then, of course, prevention strategies, right? We've got to make sure that we're not chronically straining, that we don't suffer from constipation, that we resolve any kind of obstetric trauma or factors that could have happened, so scar tissue that would have developed in there. You can't just leave scar tissue. It has a propensity to tighten over time, and sometimes the symptoms of having scar tissue don't present themselves until sometimes 15, 20 years down the road. But over time, scar tissue, wherever it spreads itself, it does this. And it just tightens, and it will influence the structures it adhere to or tie itself to. Okay, so these are just some of the treatment approaches that we utilize. And to finish, I'm just going to touch on the workshops. There are 6 workshops that I've designed over the past few years, and I run them every 6 weeks or so. Each of them focus on the root causes of pelvic floor dysfunction and what perpetuate them. So core, inner core awareness and strength. We're looking at lower extremity, which we touched on, why it's important to have the external stability there to help reinforce the function of the pelvic floor. So we look at everything down to the feet, because the feet have a huge connection to the pelvic floor, and we'll touch on that in Unit 2. Unit 3 is posture correction, which is, of course, like I mentioned, extremely important. If you're stuck like this, you're pushing down, you're not allowing for digestion, there's no circulation happening through here, and this happens to be a very common position that I see people assume daily. So we have to look at how do we restore better posture, and so I teach exercises that help you with that. And then